Bismillahirrahmanirrahim. Assalamu alaikum and very good morning to all of you. This is Dr. Sitwat Zehra, an associate professor at Dr. Abdul Qadir Khan Institute of Biotechnology and Genetic Engineering, KIBGE. I would like to welcome you all in OWSD Pakistan chapter lecture series on science and technology for sustainable development in Pakistan. The speaker for today's session is Dr. Huma Ikram. She did her PhD from Department of Biochemistry, University of Karachi. Currently, she is serving as assistant professor at Department of Biochemistry, University of Karachi. We are truly honored to have you, Dr. Huma, with us. Thank you very much, dear, for your time. The title of her presentation is Neurological Manifestation of COVID-19 OWSD Pakistan chapter. Over to you, Dr. Huma.
Okay, Bismillahirrahmanirrahim. Good morning, everybody. This is me, Dr. Huma Ikram from Department of Biochemistry, University of Karachi, and I'm also Executive Council member of OWSD Pakistan National Chapter. The topic for my today's presentation is Neurological Manifestations of COVID-19 and some basics. That is, the coronavirus disease COVID-19 is caused by the novel virus severe acute respiratory syndrome coronavirus 2, also referred to as SARS-CoV-2. And since its discovery in Wuhan, China last year, the disease has spread across the globe, leaving physicians challenged by its variable symptoms. And one of these variable complications and symptoms include the clinical manifestations, neurological disorders associated with it. And most patients infected by this SARS-CoV-2 have presented with a mild clinical course, that is beginning with fever and dry cough, progressing to a form of mild to moderate respiratory disorder, chest congestion, flu-like symptoms even reported by few, and these do resolve usually without a specific treatment, but the response depends upon the immune system and it varies from person to person. So serious complications of the infection, however, remain a central concern because we can't predict that what number of patients or which patient is exactly would present the serious complications and of what nature. That is, it could be central nervous system related or peripheral, or it could be muscle dystrophy, etc. So acute respiratory distress syndrome, acute heart injury or failure, these are few of the we can say risk factors which are being reported by the COVID-19 patients. So acute respiratory distress syndrome could be there, or heart injury or failure could be there, acute kidney injury, sepsis, the pus formation in any organ of the body, disseminated intravascular coagulation could be there, blood clot formation, life-threatening metabolic derangements could also be reported in these patients. And these things, all these disorders, all these complications are particularly found or to be reported among those with underlying comorbidities or advanced age, like people who are more elderly, people who are already having hypertension or any type of chronic illness or disease usually report these symptoms. And as knowledge of COVID-19 and its clinical appearance continue to grow, the literature has shown a significant number of infected patients exhibiting neurological symptoms as well. So although blood-brain barrier is there to protect the invasion of these different microbes and such viruses into the brain, but sometimes somehow because of the penetration of virus somehow into the brain, or because of some secondary complications, if the viral infection is there in chest or lungs, but some metabolites or somehow some metabolic derangements are there, so central nervous system could be affected directly or indirectly. So what are the major central nervous system manifestations which are being observed so far in these patients suffering from COVID-19? The very first one used to be the headache, which was reported to be the most earliest sign in most of the patients, and severity, the duration, these all things varied from person to person, from patient to patient. And some of the COVID-19 patients with neurological manifestations were initially presented with only fever and headache, and they were not showing any severe neurological complications initially. But later on, with the progression of the disease, with the progression of the infection, the neurological symptoms were appearing, and they were being managed or treated by the clinicians. So what happens if several days later than this fever and headache appearance, they develop cough, throat pain, lymphopenia, exaggerated levels of lymphocytes, and a ground glass appearance on their respective chest computed tomography images. CT scans of the lungs show this ground glass appearance. I have a figure in next slide which will show you what is meant by this ground glass appearance. An RT-PCR analysis of these patients' nasopharyngeal swabs confirmed later on the COVID-19 infection. And encephalopathy is another complication of another neurological manifestation of the COVID-19 infection. And a study from China reviewed 274 cases of COVID-19, out of which 24 developed hypoxic encephalopathy, which progressed to death in 23 and recovery in only one patient. And a separate study reported 8 patients having the encephalopathy out of 304 cases. So although the prevalence, you can say, incidence is very low, 4.2% here, 2.6% here, but you can't say that the predictability is very the uncertainty is very high, predictability is very low, that which patient would exactly develop this condition of encephalopathy. So among the deceased cases in both studies, there were higher rates of acute respiratory distress syndrome, respiratory failure, heart failure, and sepsis. So 3 other case reports of COVID-19 encephalopathy have been documented, one each from USA, Iran, and Italy, with an age group spanning 30 to 75 years, means from a middle or young age to very early patients. And all these 3 cases presented with symptoms of fever and cough initially, with no signs of neurological complication, for a duration of approximately 5 days. And after 5 days, later on, there were the onsets of confusions and asthenia, that is abnormal physical weakness. And this abnormal physical weakness was manifested by the lack of control from central nervous system. And CT and MRI scans of brain were unremarkable, differentiable. This could be easily differentiated from the healthy individuals, showing the signs of encephalopathy. EEG also confirmed this and revealed diffuse slowing consistent with the encephalopathy. Chloroquine, lopinavir, the antiviral medicines. The lopinavir and ritonavir were administered in the first 2 cases, and they recovered. They responded well. And at the time of the reporting, the first patient was critically ill, and the second had complete resolution of her symptoms. The third patient, however, showed dramatic response to high-dose steroids. And with slightly more than a week of therapy, he was back at the baseline, mentioned with a normal neurological examination. So in few cases, the clinicians used to give the antiviral treatments. In few other cases, just to reduce the inflammation, steroids were given. So it depends upon the symptoms, upon the severity of symptoms, at which line of treatment we have to use, what could be the most effective way for few patients and for others. So it is all very uncertain. The treatment methodology is also variable. It varies from patient to patient. Ischemic stroke also has been reported as another neurological manifestation or complication. And retrospective observational study from China again reported that 6 out of 214 reviewed COVID-19 cases developed ischemic stroke, that is 2.8% of the total patients. And out of these 6 patients, 2 arrived at the emergency department owing to sudden onset of hemiplegia, that is the paralysis of one side of the body without any fever or upper respiratory tract symptoms or any other symptom related to COVID-19. So they were just like presenting the paralysis, or they were presenting simply hemiplegia without having any symptom of the COVID-19. And 4 of these 6 patients were severe cases of COVID-19. And this is how hemiplegia affects your half part of the body that is affected. This is all the affected area, and this area loses the input and output signals from the brain, like the voluntary movements are not possible, and any sensations, heat, shock, injury caused to this area is not reported to brain. So it cannot send the signals to brain and cannot receive the signal from the brain. And it depends upon the area of brain damage involved. So your right, if your brain's right part is affected, you will be having your left body part being paralyzed, and vice versa. So a study from a different center in Wuhan, China found 11 patients out of 221 reviewed COVID-19 cases who developed acute ischemic stroke. And those who had COVID-19 infection with the new onset of ischemic stroke were more likely to have a severe SARS-CoV-2 presentation. Advanced age, pre-existing cardiovascular risks, hypertension, diabetes, and previous cerebrovascular diseases. So all these complications which were already present, all these pathological conditions, if they were previously present, they were at a higher risk of ischemic stroke. And an increased inflammatory response and hypercoagulable state was also more common among these patients. So increased inflammatory response was also observed, and interleukin secretion, the cytokine storm, what we say, was also observed in these patients. And 3 other cases of ischemic stroke were reported in China among COVID-19 patients age group 40 to 80 years. Each of them initially presented with a dry cough only, no fever, no other complication, and after at least 1 week, they developed limb weakness, dysarthria, that is unclear articulation of speech, linguistic center of the region of the brain, language center of the brain if it is affected, and tongue deviation. A CT scan of the brain revealed basal ganglia infarction. So there was infarction, or you can say dead muscles, dead tissues, dead cells in the basal ganglia region of the brain. In one case, while normal findings were reported in the other 2 cases, that is just swelling or mild bleeding. So this is how an ischemic stroke used to be appear. Infarction used to appear in the CT scan. So infarction or dead cells usually do appear like this. These are the normal cells, the gray and white matters, and this is the infarcted region, that is the dead region or non-functional neuronal region. Laboratory studies showed elevated D-dimer. It is a protein related to coagulation. Decreased fibrinogen level, prolonged prothrombin time, and activated partial thromboplastin time. All these factors contribute to abnormal coagulation or blood clotting. Additionally, serum cytokine levels, including interleukin 6, 8, and 10, were markedly elevated in these patients, and all 3 patients recovered with good functional outcomes after stroke treatment and supportive therapy. And this D-dimer, as I mentioned earlier, is a protein fragment that's made when a blood clot dissolves in your body. So it's related to the blood coagulation. And how it is in appearance, 3D structure. Another manifestation is intracerebral hemorrhage, which can later progress to intracranial hemorrhage. So, if it is in the right cerebrum, or it could be in the left cerebrum, depending upon that, the patient's right or left part of the body could be affected, like we observe in case of a stroke. So, another study from China reported one patient out of 221 reviewed COVID-19 cases, who developed intracerebral hemorrhage. And the patient was a 62-year-old male who was a chronic cigarette smoker, presented to the hospital with a severe case of COVID-19. About a week later, he developed intracranial hemorrhage. So initially it was intracerebral, confined to one cerebrum, but later on it became intracranial. That is within the entire brain, different regions of brain, intracranial, and he died because of this excessive hemorrhage. And of note, his blood pressure averaged 150 to 80 millimeter Hg during treatment. So at the time of presentation, during the treatment, his blood pressure already was elevated, which was not unfortunately being controlled during the passage of treatment. And this hemorrhage, which was initially intracerebral, confined to a region, become uncontrolled, becoming intracranial hemorrhage. So this is how, if it is intracerebral, it is confined either to right or left region of the brain only. But if it is intracranial, it is originating in multiple regions of the brain, and because of the excessive bleeding, pressure is also exerted on the meningeus layers of the brain, and or blood coagulation affects the supply of blood in different brain regions, and ultimately the patient can also die. There are two case reports from Iran, one of a 79-year-old male with no medical history of hypertension or anticoagulation therapy, and another of a 54-year-old lady with a history of hypertension. So one without hypertension and one with hypertension, and both presented with an acute loss of consciousness preceded by fever and dry cough. So first the loss of consciousness was observed, and then fever and dry cough. So the order of the symptoms, sequence of the symptoms also could vary. In few cases, fever and dry cough, then the central symptoms, and here the central symptom first, and then fever and dry cough. So it varies from patient to patient. And initial Glasgow coma scale for them was 7 and 10 respectively. Since the cutoff is 15, so 7 and 10 could be referred to as moderate to severe. In respect to severity, and coagulation studies were normal for both, so no coagulation was there, but this this loss of consciousness or this unconsciousness could be because of the swelling of the meningeus layer. Coagulation was not there, but initial swelling, or because of the hypertension as well, because of high blood pressure as well, in this case chronic, and in this case acute. This could be the reason that they have lost the consciousness for a temporary period of time. CT scan revealed massive intracerebral hemorrhage in the right hemisphere, accompanied by the intraventricular and subarachnoid hemorrhage for the former, and the bilateral subacute basal ganglia hemorrhage. So hemorrhage was there, but fortunately blood coagulation had not started. And this is the CT scan would have been performed in the very initial stage, and lung CT scan as done simultaneously showed bilateral ground glass opacities in both cases. So lung complications were there, lungs were affected, and the respective authors suspected the intracranial hemorrhage was secondary to infection with SARS-CoV-2 in both cases. And this is how the bilateral ground glass opacities appear in the lungs in these patients of COVID-19. Now, encephalitis and encephalomyelitis. 6 cases of encephalitis have been described from China, 2 from Switzerland, 1 from Japan, and 1 from America. and their ages range from early 20s to early to late 60s, means almost every age group was being affected, and all of them had preceding symptoms of fever and cough followed by a rapidly deteriorating levels of consciousness. The loss of consciousness was there later, and fever and cough were present initially. Meningeal irritability was reported in 2 out of 6 cases, and this is what we mean by the meningeal irritability. Because of high blood pressure, because of inflammation or anything, this is the normal meninges layer. This normal meninges layer is being inflamed or being swollen, in this case meningeal irritability, because of this irritation due to viral infection, due to inflammation, because of the higher levels of interleukins. So for whatever reason we have this inflammation, if it is there, we term it as meningeal irritability. So where lumbar puncture was performed, it showed lymphocytic pleocytosis, that is abnormally increased lymphocytes in the cerebrospinal fluid of these patients, which is typical of a viral meningoencephalitis, that is inflammation of the brain and its surrounding protective membranes, meninges layers, resembling both meningitis and encephalitis. So it's a combination of symptoms of both meningitis and encephalitis, and SARS-CoV-2 was detected in the cerebrospinal fluid as well in only 2 patients. So for one of the Switzerland patients who presented with psychosis, that is loss of touch with the reality, illusions could be there, the person could not be in the right senses, and focal status epilepticus seizures, that is similar to epileptic seizures, simple. An electroencephalogram (EEG) was done, which showed abundant bursts of interior low-medium voltage irregular spikes and waves superimposed to an irregularly slowed theta background, just what we observe in the chronic seizure patients. And it was managed with intravenous clobazam and valproate benzodiazepines, the 2 common benzodiazepines, which are usually used to treat the patients of epilepsy without having these complications of COVID-19. And she had a marked improvement 96 hours after administration of these drugs, with the resolution of her symptoms as well. So although these seizures were not of the origin of normal usual neurological disorder of epilepsy, it was secondary to viral infection, but it could be treated. It was treated with the benzodiazepines simply, the way of treatment which we use for the epilepsy patients routinely. CT scan of the brain was normal in all, but the case of American patient whose scan demonstrated symmetric hypoattenuation within the bilateral medial thalami had a follow-up MRI brain scan which revealed hemorrhagic lesions within the bilateral thalami, medial temporal lobes, and subinsular regions. So in these 3 different regions, one patient revealed hemorrhagic lesions as well because of blood loss, because of bleeding. Lesions were created, and the neuronal cells could have been dead in those regions. And in her case, a presumptive diagnosis of COVID-19 associated acute necrotizing hemorrhage encephalopathy was made, and she was thereafter started on IV immunoglobulin, the antibodies, to treat the symptoms. Acute myelitis is another complication, another manifestation of COVID-19, and one COVID-19 case from Wuhan is reported with the presentation of acute myelitis, and a 66-year-old male with a 5-day history of fever was admitted to hospital. CT scan of the chest found patchy changes in both lungs, and nasopharyngeal swab test positive for SARS-CoV-2. And after a single night of high fever, he developed bilateral weakness of his lower limbs, both limbs, with urinary and bowel control. And a clinical diagnosis of post-infectious acute myelitis was made, and he received treatment with ganciclovir, lopinavir, ritonavir, the simple antivirals, and moxifloxacin, dexamethasone, the antibacterials, antibiotics, and IV immunoglobulin, that is the antibodies, and mycobalamin. So we had different combinations, antivirals, antibacterial, and antibodies in this case. And his bilateral lower extremity paralysis ultimately improved, and he was discharged to a rehabilitation facility. So the antivirals to treat the COVID-19 and antibacterial to treat any secondary symptoms was secondary bacterial infections were given to the patient. Now coming to the apart from the central nervous system, peripheral nervous system manifestations have been reported in few patients. And what are these? The most common one being since the very beginning, although it could not be present in 100% of the patients, is loss of smell or taste sensation. That is an overall average of 59.45%. That is almost half of the patients being affected by the COVID-19. They experienced olfactory disturbance, either smell or taste loss or both. Additionally, there is prevalence of taste disorder in most of the patients. An overall average of 56.48% of the patients experienced taste disorder. So out of the 59.5% for the olfactory disturbance, out of these 56.48% patients, out of 100, 56.48 experienced taste disorder. So almost the same number. That is, majority of them reported taste disorder. But that is not necessary always that you have both loss of both sensations being affected by the simultaneously by the same individual. So some may have loss of smell only, some may have loss of taste only sometimes. And this is how the loss of smell or taste could be affected. The taste buds, the input signals to the brain, and the smell input to the brain, these could be to the olfactory bulb. So if these regions, olfactory tract is there, so if these regions of the brain, these are being temporarily affected, or the bleeding is there, hemorrhage is there, or these regions are just simply inflamed. So in either case, you have this loss of smell or taste. If it is there, then it is because of the reason that these two regions could be affected. Or if these are not affected, the infection is in any other region, and luckily or by chance these regions are not affected, then patient cannot present these loss of taste or smell symptoms. Multi-center prospective study by Layson et al. Reported time course of the aforementioned disorders, that is loss of taste and smell. And this time course also varies from patient to patient. The olfactory dysfunction appeared before, in addition, and after the appearance of general symptoms in different percentage of the cases, and it varies from population to population, relatively very low to very high. So it depends, it varies from patient to patient, from population to population. And this olfactory abnormality persisted even after the resolution of the symptoms in 63% of the cases. So in an Iranian study, majority of the patients with olfactory dysfunction reported that the onset of the olfactory dysfunction occurred at the same time or immediately after the onset of their other COVID-19 symptoms. That is, the onset of olfactory dysfunction was related to their other central or peripheral symptoms. These could be chest congestion, these could be headache, or loss of consciousness, whatever. Bell's palsy. In China, a 65-year-old woman was admitted to the hospital for a left facial droop presented by a 2-day history of pain in the mastoid region. So this is the mastoid region of the skull, a pain in this region. And the left facial droop was reported in this 64-year-old lady. And there was no preceding fever, cough, respiratory symptoms, nothing appearing like the COVID-19 infection. And physical examination showed a left lower motor neuron facial nerve paralysis. So it could have been confused with a simple hemiplegia, but MRI brain showed no abnormality as well. Simply, and only confirmation was that her throat swab RT-PCR turned positive for SARS-CoV-2 virus, and the CT chest revealed ground glass shadows in the right lower lung, despite being the absence of despite being the fact that there were no symptoms of respiratory distress disorder. The left facial paralysis was relieved after antiviral treatment simply with umifenovir and radvavirine. Both are two antivirals. Uh, Guillain-Barré syndrome and its variants. And this author have reported the 5 cases of the syndrome, GBS syndrome, in COVID-19 patients. The interval between the onset of viral illness and the first symptoms, initial symptoms of GBS, was between 5 and 10 days. Initially, these patients did not present any signs of this syndrome, but after 5 and 10 days, respectively, few presented the symptoms after 5 days, 6, 7, 8, and so it varies between 5 and 10 days. The first symptoms were lower limb weakness and paresthesia, that is burning, numbing sensations or prickling sensations that is usually felt in the hands, arms, legs, or feet, or in any other part of the body. In 4 patients, it was being observed. In one patient, however, facial diplegia, that is the facial paralysis, followed by ataxia, that is lack of muscle control, voluntarily muscle control or coordination of voluntary movement of the entire body, and paresthesia was also observed. Generalized flaccid quadriparesis, that is limp muscles that lack firmness, and or tetraplegia, that is inability to voluntarily move the upper and lower parts of the body, evolved over a period of 36 hours to 4 days in 4 patients. Symptoms were varying, and 3 patients also received mechanical ventilation. CSF analysis showed raised protein levels in 2 patients and raised lymphocytes in all 5 patients. CSF RT-PCR for COVID-19 was negative in all patients, representing that the COVID-19 had not, the virus had not invaded the central nervous system, but it only was present in the system and the peripheral system in the body. And these complications, these symptoms were secondary to the COVID-19 infection. The central nervous system was indirectly affected, not directly. So neurological examination and nerve conduction studies were consistent with the demyelinating neuropathy in 2 patients. That is demyelination, the myelin sheath had started being removed or peeled off or dissolving, while the others were diagnosed as axonal variants of GBS. So axons only were affected, not the entire neurons were affected. And all 5 patients were treated with intravenous immunoglobulin. 2 received a second course of intravenous immunoglobulin, and 1 required plasma exchange. So depending upon the severity of the symptoms or complications, 4 weeks after treatment, 2 patients remained in the ICU and were receiving mechanical ventilation. 2 were undergone physical therapy. They were recovered, but they were undergoing physical therapy for the revival of their muscle movement, and 1 was discharged without any residual symptom. 1 was completely recovered. 4 other case reports of GBS, 1 in America, 1 in Iran, and Italy and China, respectively, were reported. And all of these 4 cases had an age range from mid-50s to 70s, means elderly patients were there. And all but the Chinese patient presented with the flu-like symptoms. Only one patient was not representing this flu-like symptoms, but all of them were. And there was a preceding weakness and or the accompanying numbness of the lower limbs with a progressive ascending paralysis. And the Chinese patient was presented with neurological symptoms first and exhibited respiratory symptoms only on day 8 of admission. So initially neurological symptoms were there and respiratory symptoms were presented later, almost after 1 week. Apart from central and peripheral nervous system, there are some skeletal muscle manifestations as well, like for example myalgia and myositis. And overall, an average of 25.1% patients reported myalgia, that is the pain in a muscle or a group of muscles, in 7 retrospective studies, different studies. And the characteristics and the course of myalgia was not detailed in any of those studies, just simply a pain was reported. And it is also reported that out of 214 patients, skeletal muscle injury was also found in 23 patients. And compared with the patients without muscle injury, patients with muscle injury had significantly higher levels of creatine kinase. Obviously, this is the parameter which we usually frequently use to detect the muscle injury in the patients. Rhabdomyolysis. The case report by Jin et al., Jin and the co-workers, described a 60-year-old man in Wuhan who presented with a 6-day history of fever and cough. In a CT scan of the chest, which showed bilateral ground glass opacities. RT-PCR analysis of the patient's throat swab specimen indicated SARS-CoV-2 infection. The test was positive, and he was treated supportively and with antivirals and antibiotics. On the day 9 of admission, the patient complained of pain and weakness. Initially, it was not there. The pain in the lower limbs was not there initially, but later on it developed, and tenderness was noted on examination. Urgent laboratory reports indicated raised myoglobin, creatine kinase, lactate dehydrogenase, alanine aminotransferase, and aspartate aminotransferase. So liver functions, kidney functions, they were affected. The patient's kidney functions and electrolytes were normal. And initially, you can see that the creatine kinase levels were high, but the kidney functions, the urine TR and the functional tests were normal, representing that it is just the acute manifestation of the infection. The diagnosis was made depending upon the presentation of the symptoms, and the biochemical tests, biochemical markers were detected at a very early stage. Urine analysis or urinalysis revealed a light yellow color of the urine with positive occult blood and positive urine protein. Blood was there, some initial mild hemorrhage or bleeding could be there, and these results indicated the onset of rhabdomyolysis. And in addition to the ongoing supportive therapy, the patient was treated with hydration, alkalization, plasma transfusion, and gamma globulin. The patient improved subsequently without any antiviral therapy. Now, a few of the biomarkers which were being reported in these studies frequently, the coronavirus contains 4 structural proteins like spike proteins, envelope proteins, membrane, and the nucleocapsid proteins. S protein plays the most important role in viral attachment, fusion, and entry into the host cell. The SARS-CoV-2 recognizes the angiotensin converting enzyme 2, ACE2, as a host cell entry receptor. And the high expression of the ACE2 receptors is seen in type 2 alveolar cells of the lungs, intestine, esophagus, cardiomyocytes, proximal tubular cells, and urothelial cells. So in different multiple types of cells, multiple type of organs, you can find this ACE2 receptor elevations or elevated expressions. Glial cells and neurons have been reported to express ACE2 receptors, making the brain a potential target of COVID-19. Since ACE2 receptors are being expressed in the glial cells and neuronal cells as well, so the viral particle COVID-19 can also attach excellently to these regions expressing ACE2 receptors. And this is how it attaches. The glial cells and neurons have been reported to express these ACE2 receptors, making brain a potential target. This is how SARS-CoV-2 firstly enters into the blood circulation of the brain and then attaches wherever it finds the ACE receptors in the glial cells. And this is how The receptor binding domain of a spike protein binds to ACE receptor. So this is ACE receptor, and this is the how the domain of the RBD domain of the spike binds to the receptor ACE2 naturally present in the glial cells in few neurons. Now, routes of entry, which have been reported so far. So, how the virus enters the central nervous system is still a subject of debate. One possible route of entry is through the olfactory nerve, very easy passage, and retrograde transfer into the axon, whether through the synapses, endocytosis, or exocytosis, could explain viral migration into the brain. Experimental studies using transgenic mice suggest that SARS-CoV and MERS-CoV may enter the central nervous system intranasally as well, through the nose, through the olfactory nerve. And once in the brain, they have the potential to spread to the thalamus, particularly, and brainstem, two regions which are highly involved in the coronavirus infections or COVID infections. In a study evaluating specific receptors in the nasal mucosa, however, suggests that SARS-CoV-2 may reach the brain through mechanisms independent of axonal transport via the olfactory sensory nerve. So, without being axonally transported, it can simply enter through the olfactory sensory nerves. And another theory suggests that if SARS-CoV-2 gained access to the general circulation, peripheral circulation, it could potentially invade the cerebral circulation and continue viral spread. And slow movement in the cerebral microvasculature may promote interaction of the SARS-CoV-2 S protein and capillary endothelium ACE2 receptors. Now, once bound, the virus would have the potential to infect, damage, and bud from the capillary endothelium, thereby facilitating viral entry into the cerebrum, and it again can keep multiplying in the brain, and infection could spread more and more. And this SARS-CoV-2 could also damage the central nervous system indirectly. And how does this happen? Viruses do not have to enter in the brain to cause damage. They only can activate an immune response that triggers subsequent damage within the neuronal tissues. So you may have the rush of or gush of the interleukins, the mediators of the immune system, and they can affect or directly or indirectly the brain by just causing inflammation in the brain, high blood circulation, or whatever. So SARS-CoV-2 has been reported to cause a massive release of cytokines, a syndrome known as cytokine storm. Downstream effects of this immune response include endothelial damage and disseminated intravascular coagulation and disrupted cerebral autoregulation. So all these things indirectly can affect the brain, although the viral particles have not invaded into the brain, but they indirectly by these mechanisms can cause damage to the brain and can affect the central nervous system functions. Now, some of the common symptoms which have been reported so far. The common central nervous system related symptoms elucidated in all of these studies included myalgia, muscle pain, headache, altered sensorium, that is whole sensory apparatus of the body, it is affected, senses are affected, hyposmia, that is decreased sense of smell, hypoacasia, that is decreased sense of taste. Acute viral respiratory tract infections have already been reported to cause all of these symptoms which are concerned with related to the central nervous system. Peri and post-infectious hyposmia and hypoxia, hypogasia, that is the loss of smell and taste, is hypothesized to be secondary to olfactory nerve and or olfactory damage, or olfactory apparatus damage. So this olfactory nerve could be partially affected because of inflammation or pressure triggering because of the adjacent brain regions affection. Or it could be because of the direct insult of viral infection, or this olfactory nerve could be directly affected by the viral infection or invasion. And according to the multi-center prospective European study, It appears that a large number of COVID-19 patients experience olfactory and gustatory symptoms. The loss of taste and smell have been reported so far. The most common symptoms, most common manifestations of COVID-19 infections. And we found that in COVID-19 patients, these altered sensorium and encephalopathy were not common, not comorbid. And the basic pathological changes seen in this disease is cerebral edema, swelling of the brain, with key clinical features being headache, confusion, delirium, that is the disturbed state of mind, and there could be loss of normal processing of information. Patient could not be in the right senses to take a decision. Loss of consciousness could be there, seizures could be experienced, and ultimately, in most severe cases, the patient might experience coma. And few of the patients with encephalopathy were mostly older males, older male patients with cardiovascular comorbidities. They already had a previous history of cardiovascular disorders, severe infection with systemic inflammation, and multi-organ dysfunction. An early identification of early diagnosis of these patients with altered sensorium, altered senses is critical, as underlying potential reversible causes, including impending respiratory failure, require timely intervention. So if their altered sensorium is timely treated, the underlying potential treatments could be, the underlying potential causes could be determined, and they could be treated in time. Otherwise, the loss, the damage to the brain is sometimes completely irreversible. In most of the cases, it is irreversible. And the pathophysiology behind the cerebral dysfunction is hypothesized to be in part inflammatory mediated. So in most of the cases, the cerebral dysfunction was because of, it was secondary to the inflammatory mediators like interleukins and others. And few, like we have mentioned previously, few of the patients have also recovered just by the treatment with steroids or the treatments, the manifestations which can lower down the interleukin level, which can decrease the inflammatory response. And this is supported by the fact that the encephalopathic Italian patient had a dramatic response to high dose steroids. So sometimes even steroids can work, can control this, the steroid storm or immune storm. Ischemic stroke is another clinical entity which could be present in patients with COVID-19 infection. And stroke, if it is there, it can lead to the terminal dysfunction of the brain region, particular brain region, if not treated timely. And this presentation of ischemic stroke may arise secondary to a cytokine storm syndrome, which can cause endothelial damage, disseminated intravascular coagulation, and disrupted cerebral autoregulation. And through the ACE2 receptors of the vascular endothelium, the viruses, extensive invasion of the vascular endothelium obviously may cause extensive endothelitis, infection of the endothelium layer, and which increases the risk of thrombosis leading to ischemic stroke. As the thrombi can become stuck in the capillaries, and this may decrease the blood supply to the different regions, causing the infarction. Critically ill patients, because of any disease, if they're critically ill and they also have SARS-CoV-2 infection, often show elevated levels of D-dimer, which is a fibrin degraded product which serves as a marker of dysfunctional activation of the coagulation system, such as in acute ischemic stroke. So this dysfunctional activation of the coagulation system could be there. Blood clots are being formed but are not adhered to the endothelial layer, so they remain mobile, and they can block the blood supply by getting stuck into any capillary, and this may cause also the stoppage of blood supply to any region in the brain and can cause damage to that brain region. However, it is observed that the stroke is not always comorbid in COVID-19 patients. In all of the COVID-19 patients, you can't observe the stroke. So if it is treated in early stages, if it is diagnosed timely even, and treated appropriately, the patients don't usually present the signs of a stroke. For the cases of COVID-19 associated intracerebral hemorrhage, reduced expression and function of ACE2 proteins are responsible. So if we control somehow the expression of these ACE2 proteins, if we inhibit them somehow, then we can have this reduced intracerebral hemorrhage. And this reduced expression and function of ACE2 proteins could potentially lead to uncontrolled hypertension, arterial wall rupture, and cerebral hemorrhage. So we have to manage their expression if possible, because their decreased expression may lead to these complications like hemorrhage, arterial wall rupture in these infected patients. It's still unknown that how these COVID-19 patients, in these patients, encephalomyelitis is being caused. It is thought that the once viral particles gain entry into the neuronal tissues, their interaction with the ACE2 receptors in the neurons could initiate a cycle of viral budding, accompanied by the neuronal damage. And that is how at the same time the virus is causing the damage, as well as it is replicating quickly to spread the infection. And this can occur without substantial inflammation. Inflammation could not be observed in initial stages. In other cases, it may cause an acute inflammatory demyelination. And in some cases, immediately after the entry of COVID-19 viral particles into the brain, we can observe the inflammatory demyelination. There could be inflammation as well as demyelination, or removal of the myelin sheaths from the supporting cells, could be observed in patients. And it all depends upon the strength of the infection, as well as the progression of the infection, at what pace it is progressing, plus the treatment strategy, whether it is effective or not. And acute hemorrhagic leukoencephalitis is a rare demyelinating disorder that is usually fatal and is observed in these patients with COVID-19. And ICU care, use of high-dose corticosteroid therapy, immunoglobulins, plasma exchange, dehydrating agents. These are the different strategies which were used to increase the survival rate, but these were only implicable in few patients. Not all of the patients responded well to these therapies, these random therapies. And 3 neuroimmunological entities related to COVID-19 infection have been reported so far. That is acute transverse myelitis, GBS syndrome, and Bell's palsy. These are the 3 peripheral, you can say, manifestations of the COVID-19, and this suggests that the underlying mechanisms of such neuroimmunological phenomena in the COVID-19 patients is having a molecular mimicry. So the actual, normally the pathophysiology of these disorders have nothing to do with the COVID-19 infection or any viral infection. These were considered to be just like metabolic disorders because of neurotransmission irregularities or abnormalities. But in COVID-19 patients' cases, the symptoms were exactly like those which usually are present in the normal pathophysiologies without viral infection. So there was a molecular mimicry only between microbial and nerve antigens in this case. So COVID-19 patients had these disorders only because they were having few other complications. The basic reason in both of the cases, COVID-19 patients and non-COVID-19 patients, the basic reasons were different, but symptoms were similar only because of this molecular mimicry. But the sole cause, sole reason, and therefore the treatment strategy in both of the cases would be different. So in conclusion, the sum of the entire presentation, we comprehensively overviewed several different neurological manifestations of COVID-19 reported so far from different studies, mostly from China, but from other parts of the world as well. And the respiratory symptoms remain the hallmark of early identifications. cohorting in treatment of COVID-19, but with patients with neuronal complications did not present the respiratory symptoms all the times beforehand. They initially, some of the cases were there in which neurological complications were present initially, and respiratory symptoms came or were being presented much later. So it varies from person to person, but most of the times, in majority of the patients, around 80 to 90% of the patients, respiratory symptoms were preceding the neurological or peripheral, central, or other complications. And we have to bear in mind that in a number of cases, it has been observed that the neurological manifestations may precede it in the course of disease. So, therefore, an attention should be given in this case to determine the underlying cause of like COVID-19 in the current scenario. If the person is coming with these neurological manifestations, one secondary thought initially should be given to the COVID-19 infection, because the entry through the nasal route or oropharyngeal route is very easy of this COVID-19 virus. And a few references, the very valuable studies which reported the different case reports or different case studies in few this was a review of several cases. In few others, it was just a simple, complicated one, two, or three case only. So these are the different studies which I consulted for preparing this presentation, conducted throughout the world. And this is thank you from my side for your time and attention.
Thank you so much, Dr. Huma, for such an elaborative and very kind lecture regarding neurological manifestations during COVID-19. My first question with you that how we can have any kind of a resiliency programs during this COVID-19 to administer, so people can have some psychological illnesses, and those illnesses would be overcome through the neurological manifestations. And I would like to appreciate all the participants to please put your question in a chat box. So Dr. Huma will answer one by one to all the question answers. Thank you so much for attending this event. Yes, Dr. Huma.
The only things which I discussed in today's presentation was the clinical manifestations, neurological. The one thing which I skipped because of the shortage of time, and it is of great importance because it is affecting far more greater number of people in the population, is the same which you have mentioned. That is the stress, anxiety, depression prevailing in the patients as well as in the family members of the patients, even in the general population, common individuals, even a layman, because they are very much afraid of the things that the virus may contract them through any route. Things were not clear initially for all of us, but still the layman or normal common people have very little information about the sometimes the virus is infected, the people contract virus despite all the precautions they take. So obviously, there should be a resilience program or something strategy like that to for you to remain stress free. So very best thing is to maintain the hygiene and to get aware of what's happening around, and don't get panicked. Uh, the cases we have reported were of because of the complications in people with underlying disorders already present chronically, like cardiac, most of them cardiac patients, hypertensive patients, and very few the central nervous system manifestations were present acutely, that is without any underlying abnormalities present previously. So the take-home message would be to stay calm, stay informed, take all the proper precautions, and it is nothing just like another viral infection. Just you have to do your best and don't get panicked, and do seek the medical advice at right time, because as we mentioned, symptoms varied from person to person, and if acutely diagnosed, these could be treated in time, and there is no such complication was there in patients until unless they were presented very late or remained untreated. So this is a great need of, and also we can join some programs, some training sessions in which to we can keep ourselves very well aware, and we can adapt the strategies to remain stress free, healthy lifestyle and all.
Okay. Thank you, Uma. Such a nice answer to my question. My other question is by Dr. Ishrat Jameel. She's asking that what is myalgia and what are glial cells?
Okay, viralgia, simply the viral infection, viral particles, and the glial cells. Glial cells are supporting cells in the brain. The neuronal cells do perform their functions, and the glial cells are rich cells. You can say fat-rich cells. They don't contribute directly in the neuronal transmissions. Neuronal cells contribute directly in the neuronal transmissions of signals, sensory inputs, and the decisive outputs. But the glial cells are supporting cells. They are metabolically active. They do perform some metabolic functions for the neurons, supporting neurons. They're also called as different types of glial cells are the astrocytes and others, and these are simply the supporting cells, you can say, supporting the functions of neurons, but they are not directly involved in the neuronal functions.
Okay. I also encourage all the participants who are attending this seminar that put your question in a chat box, then I'll ask that question with Dr. Huma. So you'll be able to get your answer in that. Dr. Ashrat is again asking Dr. Huma that is there more chances of COVID-19 in epileptic and Alzheimer's patient? Any suggestions or what are your thoughts?
What I presume, what she's asking, that the people with already suffering from or having, and the people with neurological disorders already, like epilepsy, Alzheimer's, or related Parkinson's, could be others. They are at more risk to these clinical manifestations of the COVID-19 if they contract COVID-19. Then yes, because already they have an abnormal dysfunctioning of brain, like in few cases in Alzheimer's you see the damage to brain already has started. The brain is partially 2%, 1%, whatever, it is already damaged. In schizophrenia, there are abnormal activations of the dopaminergic neurons, not damage to the brain, but hyperactivity of few regions, and obviously because of that, hypoactivity of few other regions. Acetylcholine neurons, for example, they are hypoactive in the Parkinson's patients. Same goes for schizophrenia. So obviously they are at more risk. Just like we mentioned, elderly patients, people with hypertensive history, they are at more risk, but and obviously they have to take more care.
Okay. Some other people are also raising their hand and they would like to ask the question. Mariam Jameel. She's raising her hand. Mariam, open up your mic and ask your question, please. Or put it in a chat box. Hafsa Junaid, go ahead and ask your question. Hafsa Junaid. I've already allowed you to open your mic. Yes.
Ma'am, are
Yes.
corona patients also suffered by heart attack diseases or typhoid diseases?
Like you mean that heart attacks, cardiac arrest, and typhoid before or after COVID-19?
Before suffering from COVID.
Okay. Yes. Okay. So typhoid has nothing to do. It is a bacterial infection simply. An immune system is affected. So you can see that the immune system usually is revived. You have cell cycle of 120 days for RBC synthesis, and all the cells are revived. Okay. And in the history, T cells, B cells can memorize the antibody information, and they can synthesize whenever antigen next enters into your body. So if the person is infected or vaccinated with typhoid for typhoid, he or she becomes resistant to typhoid. So it has nothing to do with the you can say COVID-19 complication. But in case of those individuals who are cardiac patients, if they have myocardial infarction, if they already have abnormal levels of the cardiac enzymes, or some region of the heart is already affected, then in that case, if COVID-19 manifested, if a COVID-19 infection is untreated for a certain time, lately diagnosed, affects the cardiac tissues, that obviously, if the cardiac tissues are already weak or damaged, they would be more prone to further damage.
So this means it's not linked with COVID-19, means typhoid.
uh, no, it's not like relationship is not there. It is not there like always the individuals who have the previous history of myocardial infarctions or heart diseases or typhoid have more, you can say, predisposal to COVID-19. But if you are taking it like this, person's immune response is weak, presuming that he or she had a typhoid infection previously, if you are taking it from that point of view, then you can presume that they are more susceptible to COVID-19 infection. But in that case, also, if you have the timely report of symptoms to the clinician, and if the COVID-19 infection is diagnosed initially at very early stage, then the proper treatments, even if the interleukins are not being synthesized, we can infuse IV immunoglobulins. So depending upon the proper assessment, you can start the treatment.
Ma'am, my father was died due to COVID-19. First, he was suffered by typhoid, and at the last, he suffered by heart attack.
So it happens, when the person is being infected by the viral particles, viral infections, and if it is so severe and remains untreated, undiagnosed, and then untreated, then as a result of complications and immune system is being burdenized, secondary infections also may arise, like bacterial infections such as typhoid. And if during the progress of the disease, during the progress of prognosis of COVID-19, the cardiac, because you see, as a result of immune response, increased immune response, the gush of blood, specifically we have mentioned the cytokine storm, the blood supply usually is increased to all regions of the body. And if cardiac tissues are affected, so it might have been the case that in this case, when the COVID-19 infected person was having a typhoid infection, chest function, maybe acute respiratory distress syndrome was also there. Obviously, lungs were affected, the typhoid, and later on the heart. Because if lungs are affected initially, they will restrict the decreased blood supply to all the organs, and cardiac tissues are very sensitive to oxygen supply, blood supply. So you can see that these were because of the complications. You can say these were because of the secondary manifestations that they observed, the typhoid and myocardial complications, infarction in the later stages of COVID-19, maybe because of late diagnosis and late start of the treatment.
Yes, ma'am. Thank you, ma'am.
Ma'am, I have a question.
Yes, I can listen you.
Yeah, ma'am, there are some of the cases in which the
the COVID is asymptomatic, not showing the symptoms like fever, flu. But if it is harming the central nervous system, if it is affecting the CNS directly, so what the person should do means the person is not sure whether he is suffering from COVID or not. So at what time, what the person should do?
Okay, so obviously, in case of this pandemic era, you know that the diverse symptoms could be there, and you may not, as we have also mentioned, that in few of the very severe cases of the central nervous system affected COVID-19 cases, patients, we had no presentations of the flu-like symptoms initially, no cough, no chest congestion initially, but it appeared later on. So initially, the sequence may change of the symptoms, but these are there. Sooner or later, they appear. So if the person is initially suspecting that he had or she had no history of the central nervous system malfunctioning, unconsciousness, like we mentioned, the pain in the muscles, abnormal pain in different muscles, partial loss of the voluntary movement, then he or she must have to consult the doctor and have the RT-PCR test done as soon as possible.
Okay, ma'am. Thank you.
Our next question is from Miss Arisha Zedi. She's asking that what are the long-term effects on psychology of a patient, and what do you think that the seizures could lead to the psychological impairment or not? Your thoughts, please.
Yes, it all depends upon the severity of the infection and the region of the brain being affected. Like sometimes the uh, central nervous system effects mediated are because of simply inflammation, and they go away with the patient recovering with the COVID-19 infection. But in some cases, if the COVID-19 infection remains untreated for longer durations, the patients report the symptoms very late, the diagnosis is made very late, or appropriate required treatment is started at a very late stage, and the damage to the brain is done already, then it could not be reversed. So, in that case, the person may suffer from further neurological complications for the lifetime. Now,
I would like to appreciate the opportunity to get all the question answer session at this moment. Can we have some more questions or no? Okay, if we do not have any more questions, I would like to thank Dr. Huma for accepting our request and serving in a better way as a executive council member for the OWSD Pakistan National Chapter. And I would like to thank you to take some time with all these COVID situations and your personal responsibility and come to deliver the lecture on Saturday, that is the weekend over here. So I'm really grateful for you, and we would like you to give you the feedback, whatever we are going to get from all the participants, and hopefully we will call you again next time for another manifestation. Thank you so much.
thank you so much, Saima, for inviting me. It is always a great pleasure to be engaged in such activities, especially on Saturday, which is leisure day for us. We have nothing to do much regarding our academic activities. And I like the participation of all the different faculty members and students and OWSD members, and I'm highly thankful to them for their engagement and the active participation in the session. And even if they have any other query which we can discuss, or we can also conduct another lecture, which was in my mind, but because of the shortage of time, I skipped that portion clearly, and that is the manifestations you can say mental health being affected in common individuals in common population because of the this fear, this anxiety prevailing because of this COVID-19 infection. So we also can, if you can, you can suggest it if there is any field of other comments in the feedback session, feedback form. If you have it, you can mention it. If you want any other lecture related to this, like COVID-19, how it is affecting the mental health of a general individual, which is not affected directly, but those who are associated somehow with the hospitals or labs, um, doing the tests, watching the patients every other day. Obviously, stress and depression levels in those individuals is very high, and even those individuals who are learning about, who are firstly at first hand watching some family members suffering, and the things they do observe and experience because of the quarantine period, or people quarantining in some region of the house, and how mothers are there, they are being suffering from the disease, and they have to be like kept away from the children, even newborn to 3 years old, 4 years old. So there is obviously panic disorders, anxiety, depression. People are bound to stay in home for long reasons. Kids especially also don't understand much about the situation. And we also observe 2.5 year, 3 year, 4 year old children who miss their schools. And obviously, we all are social. Men are social animals. So we love to interact. We love to go out, obviously, and this is sort of constrained. We don't have to go out that freely, so that our work somehow is affected in one way or the other. So that is another thing which we can uh, discuss, and we can take into account that how consultations or what methods we can adapt to like stay away from that negative energy, from that depressive thought of being getting infected anytime. Or okay, if someone has to be like contracting the viral infection somehow at some time, obviously there's a chance factor, anyone can contract, but the proper treatment strategy, you have to stay calm, you have to take appropriate step, take medical advice timely, appropriate treatment, so it would not affect you that much, hopefully, inshallah. So the management or mental health management is another thing which we can address. But today's lecture was very excellent, and I came here at Dr. Saima's office, and I am very thankful to her for facilitating me for this lecture. I'm very thankful to all the OWSD members. Thank you so much.
Always my pleasure, Dr. Huma. Thank you so much. Have a nice weekend.